Welcome to Made One Pager. My name is Benjamin, and today I'm going to be talking about hyperosmolar hyperglycemic state. And this is another diabetic emergency. And long ago in all the literature, it was called hyperosmolar hyperglycemic non-ketotic coma. But they have moved away from this nomenclature because the coma has been found to occur in approximately just about 20% of patients. But we're going to look at this condition in detail. We're going to see the management, the complications, and many other things. And at the end of the video, we shall compare and contrast it with DKA, which is diabetic ketoacidosis, for which I made another video about it, and you can check that out. So, HHS, or hyperosmolar hyperglycemic state, is a life-threatening metabolic condition, and it's most commonly going to be found in patients with type 2 diabetes. And this is because we're going to have severe hyperglycemia, and we're going to have extreme hyperosmolality. We're going to have profound free water loss and dehydration and absence of significant ketoacidosis. And this is going to be due to the partial insulin activity. So in this people with diabetes mellitus, they're going to be having maybe a relative deficiency of insulin. And it's relative because it's not that they don't have the insulin, that they have decreased sensitivity to the insulin. So because of this, and other factors that are going to come in, like decreased water intake, inability to take the water, or unavailability of that water, they're going to develop a severe hyperglycemia and an extreme hyperosmolarity because of the decreased intake of water and also the hyperglycemia that is causing diuresis of that water. And they're going to have more ketoacidosis because much as they have decreased insulin sensitivity, the insulin is there. And this insulin is going to be just enough to suppress the formation of ketones. So it is found to have a higher mortality than DKA, and this is because it occurs mainly in older age group, and it has a delayed presentation, and it causes severe dehydration that leads to shock, and there is multi-organ dysfunction. So when we look at the pathophysiology or the mechanisms of this condition, HHS, we're going to have hyperglycemia, and this is going to come from severe insulin resistance or insufficient insulin, because as type 2 diabetes evolves, sometimes because of this continued hyperglycemia, the beta cells of the pancreas work harder. As they work harder, they die faster, and this is going to later cause on the insulin deficiency, but that began as a resistance. And then we will have a rise in the glucose levels, and this can go as high as 600 to 1,200 milligrams per deciliter. So it's very difficult to find someone having HHS and they're having blood glucose levels less than 600. It's rare. So as these glucose levels climb, the well-known threshold, so most of the time, most of the glucose that goes into the kidney is reabsorbed, but there is a threshold, and when this threshold is exceeded, we're going to have the glucose escaping in the urine, and that is glucosuria. And as we are escaping that, as the glucose escapes in the urine, it's going to go with a lot of water and cause osmotic diuresis. That osmotic diuresis is going to cause a whole number of other things, including loss of electrolytes. And the patient is going to enter dehydration. So when the patient gets dehydrated, they're going to lose about 8 to 12 milliliters of fluid, and on average it is 9 liters of fluid. And there's a massive electrolyte loss. That is things like sodium, things like potassium, magnesium, and phosphate are going to be lost. And the severity of this is going to be greater than DKA or diabetic ketoacidosis, and this is because of the slower onset. So the fluid loss is accumulated. We didn't have a slow but steady loss of fluids, and often also in these elderly people, they have a decreased perception of thirst, and therefore they have an inability to self-hydrate. Then as this continues, as the dehydration evolves, the osmolarity of the blood is going to increase. And when you look at the effective osmolarity, most of the time it's measured by by this equation where you multiply 2 times the sodium in milliequivalent per liter plus the glucose divided by 18. So you'll find that as the glucose rises, we're going to have the serum osmolarity also rising. And remember, water is going away, so the blood is becoming thicker and thinner if you have to think of it in that way. Then the high osmolarity is going to start pulling water from the surrounding, from the extravascular space. And if it's in the brain, you're going to have neuronal shrinkage, and that is going to result into altered mental status. It can result into seizures as well as coma. Then because of that little insulin like is still produced from the pancreas in people with type 2 diabetes mellitus, we're going to end up having minimal ketosis, because that insulin is going to prevent lipolysis, it's going to block passive ketogenesis, and therefore when you look at the pH and the bicarbonate are going to remain normal. And that is going to be very, very important, the differentiating it from DKN. So the clinical features, the condition is going to evolve over days to weeks, and the symptoms, some are going to have polyuria, they're going to have polydipsia, they're going to have weight loss, they're going to have severe dehydration. And the neurological manifestation are going to include confusion, and they're going to have seizures, focal deficits, and coma. And then the underlying illness signs may also be present. Someone may be having a UTI, someone's having a pneumonia. These are all going to manifest, or they're going to precipitate the condition, and they will also have manifestations of disease. Then abdominal pain is going to be uncommon, unlike when so in DKA, these patients don't commonly have abdominal pain. So when you do the investigations, you need to do the RBS, that's random blood sugar. You want to do electrolytes, you want to calculate the serum osmolality, and so the formula that is 2 times the sodium plus the glucose divided by 18. And then you want to do arterial blood gases and venous blood gases to see what's going on. Are we having the acidosis or not? You want to see are there ketones, that's a beta hydroxybutyrate, and most of the time in HHS we don't have ketones present, they're in rare, and then the creatinine for the kidney function. So when we look at the corrected sodium, this is very important, because as glucose increases or as osmolality increases, we have to correct for the sodium. Otherwise, the value we are getting may be either too high or too low. So the corrected sodium is going to be the sodium that we get plus 1.6 multiplied by the glucose minus 100, and you're going to divide that by 100. That is going to give us the corrected sodium. Then when you do the ECG, we need to do the ECG in case we are having these changes in potassium. If you watch the video for DKA, which I explain in detail how the potassium comes about to be diminished, but majorly it's because we are losing it in urine with the glucose. And then we want to find the precipitating factors. So we want to do CPCs, we want to do blood cultures, we want to do chest x-rays, troponins, because myocardial infarction can be a very important factor here. And then the lipases, where we suspect probably a patient could be having a pancreatitis. Then when this patient has seizures, we may need to do a CT to rule out other causes of seizures. And then the management, you want to correct dehydration. Most of the time when you correct dehydration, even the sugars are going to go low, because these sugars are happening because of our concentration, because of the decrease in the amount of water in the intravascular space. So as you correct dehydration and osmolality, you're going to basically have a lot done with the management, and it has to be done slowly. And this is because if you do it very fast and you restore the osmolality, the neurons are going to take up a lot of water very fast because of that change in the osmolality. So by osmosis, water is going to enter the neurons, and when it enters the neurons at a very fast rate, they're going to have cerebral edema. That patient will have deterioration. So you want to stabilize the patient. It's important to remember coma is one of the presentation of this condition. You want to protect the air if this patient cannot. You want to give oxygen if they are hypoxic, and you want to have 2 IV lines inside. You want to have a Foley catheter in to monitor the urine output and also monitor the vitals. So when it comes to the fluid therapy, and this is a cornerstone of management of HHS, what's going to happen is that in the first 1 hour, you want to give at least 1 liter of normal saline. That is 15 to 20 ml per kg per hour. That is what should be given within 1 hour. That is approximately 1 to 1.5 liters in a normal or an average person. Then after 1 hour, you're going to now look at the sodium, and you try to calculate the corrected sodium. If the calculated sodium is high, you want to now give high strength normal saline, that is 0.45% saline. If the corrected sodium is low, you want to continue with 0.9% saline. And then the target is that you want to drop the glucose level by about 50 to 70 milligrams per deciliter per hour, and while dropping the osmolality by 3 to 8. You don't want to do this very fast. You do this very fast, so every edema is going to come. Then when the glucose reaches about 250 milligrams per deciliter, you want now to give D5 in half strength normal saline, and this is because you don't want to precipitate again hypoglycemia in this patient. Then Insulin. So insulin is started a bit later on in people with HHS. The first give the fluids, because the fluids are able to cut the glucose by much. Then later on, you want to start giving the insulin, and sometimes the insulin will be given early if we significant ketosis. And unlike DKA, we would start with a lower dose of insulin that is going to be 0.05 units per kg per hour, that is intravenously. And if the an inadequate fall in the rate of falling of glucose, that is the 50 milligrams per deciliter that we want to achieve. If you are not achieving that, then you may want to double that rate. And at the glucose levels, when the glucose levels reach now 250 to 300 again, we want to reduce the rate of infusion of this insulin. And then we want to give D5 fluids. Then the potassium, you want to always and be careful with the potassium whenever you're giving insulin. If a potassium is less than 3.3, you want to reduce to all the insulin and give potassium until you're greater than that. If it's between 3.3 to 5.3, you want to give some potassium as you give your fluids. Then if it's greater than 5.3, you basically just monitor. You do not give potassium supplementation. Then other electrolytes that can be deranged can be phosphate, can be magnesium, and those are all going to be lost in the urine when you have that diuresis. And then we have to manage the precipitant causes. Sometimes we give empiric antibiotics for sepsis. You want to manage myocardial infarction if it's there. You want to manage stroke, you want to manage pancreatitis, and then stop the offending medications. Then the monitoring has to be close and continuous. You want to do hourly glucose. You want to do electrolytes every 2 to 4 hours. You want to have a strict input and output chart. You want to do neurological examinations frequently. And you want to do ECG monitoring if the potassium is unstable. Then the criteria for resolution is that if the glucose is less than 250, osmolality is less than 300, and the patient is back to mental baseline, they have hemodynamic stability, dehydration is corrected, and there is no active ketoacidosis, then we can say we have resolution. And when we have resolution, then we can now decide to transition these patients back to subcutaneous insulin. And to transition someone to subcutaneous insulin, they should be very alert. They should be able to eat. And then when you give a subcutaneous basal insulin, you want to give it about 1 to 2 hours while continuing the IV insulin. And we saw that also in DKA, because sometimes the subcutaneous insulin takes a bit of time to kick in. So you want to give it time to kick in and create that kind of overlap, so that by the time it begins working, the patient has not decompensated back. Then the prevention, you want to ensure good diabetic control. Hydration indication is very important in all diabetic patients. And basically, when you look at the diabetic, one of the components that's very important is the water or the hydration bit of it. You want to have the sick day rules. That's when the patient, one they should do when they fall sick, because normally when these patients are sick, they have higher insulin requirements and require to be on IV insulin. Then you want to treat infections early and prevent harmful medications like steroids that are counter insulin or that can cause spikes in glucose levels. The complications, you have the early complications, and that is going to be shock. As patients are losing a lot of water, so then they're going to come with hemodynamic compromise. They're going to have seizures. Now they can have acute kidney injury because of hypoperfusion and the rhabdomyolysis and disseminated intravascular coagulopathy because of this propensity of thromboembolism in these patients. The treatment-related causes, we have cerebral edema that is going to occur because of the rapid osmolality fall, hyperglycemia, hypokalemia, and fluid overload. Then thromboembolism is going to come because of the hyperviscosity. As we lose water from the blood becomes thicker, and normally we give prophylaxis for DVT with low molecular weight heparin. So when we look at the differences between DKA and HHS, when you look at the onset, DKA starts within hours, while HHS takes about days to weeks, and the glucose levels in DKA are between 250 to 600, while those of HHS are going to begin at 600 to 1200. The pH is going to be low in DKA, while the pH in HHS most of the time is going to be normal. Bicarbonate is normal in HHS, but in DKA, bicarbonate is going to fall because of the acidosis. Ketones are high in DKA, they are low or absent in HHS. Osmolality is mildly increased in DKA, and it's going to be severely increased in HHS. Dehydration is moderate in DKA and severe in HHS, where we use up to an average of 9 liters. And insulin therapy in DKA is going to be higher dosage than that one of HHS. So we have come to the end of this video. I hope you learned a lot about HHS, and I hope you enjoyed the video. If you did so, please do subscribe to the channel, share it with a friend, and don't forget to drop a like. This is Benjamin, and this is Nego Mpeja. Till we meet again.